Yeah, now we move on to the last topic, and I invite Dr. Padma Rekha Jirge, who is the scientific director of the Shushruth Assisted Conception Clinic and Shreyas Hospital, Kolhapur. She is a managing committee member of the PCOS Society, and she's also the deputy editor of the JHRS, the official journal of Indian Society of Assisted Reproduction. She is a clinical research fellow in ERT from University of Glasgow. She's trained in operative laparoscopy and hysteroscopy at Glasgow. She's a national corresponding editor for the Journal of Obstetrics and Gynecology of India. She is reviewer for the Fertility, Sterility, Human Fertility, and Reproductive Biology and Endocrinology journals. She is the executive vice chairperson of the Maharashtra chapter of ISAR and managing committee member of the Fertility Preservation Society and the PCOS Society. And she's an elected member to the representative committee of the West Zone of of RCOG. And I invite her to talk on PCOS and clinical pregnancy loss. Over to you, Rekha.
Yeah, am I audible?
Yes, yes.
Yeah. Good evening, everybody. Thank you, Madhuri, for that kind introduction, and thank you, Drusha ma'am, for always, putting up this excellent academic activities, COVID or not, just to keep us going in a very meaningful way. So this evening,
Rekha, your slides are not seen?
Not seen?
No.
Now?
No, not yet.
Okay.
Yeah.
What about now?
Yes.
Yeah.
It's coming.
So, throughout the afternoon and evening, we've gone through various challenges faced while treating women with PCOS. And one another aspect is to look at whether PCOS has any association with increased clinical pregnancy loss. Obviously, by clinical pregnancy loss, we mean pregnancies which have progressed beyond biochemical pregnancy and visible on ultrasound. We know that PCOS is the commonest cause of anovulatory infertility in women of reproductive age, and it's the commonest endocrinopathy experienced by them. And we have gone through the wide range of reproductive dysfunction experienced by these women during the course of this workshop, which encompasses not only infertility, but also various pregnancy-related complications. And one of them is considered to be an increased risk of early pregnancy loss and also probably recurrent pregnancy loss. So during the course of this talk, we'll just see what evidence is there to support this concern. And if so, what are all the causes that could be leading to an increased risk of clinical miscarriage, and whether there are any beneficial interventions to reduce the risk of miscarriage. Now, if we look at the evidence, first and foremost is to define the PCOS and identify studies which have actually utilized one of the recognized definitions of PCOS, that is either NIH or Rotterdam criteria, which came a little later. And all these studies which I've shown here have used either one of the two definitions, that is presence of clinical and biochemical hyperandrogenemia and oligomenorrhea. Plus some of them have considered the presence of PCO morphology and some of them haven't. So all these studies have shown an increased risk of miscarriage, clinical miscarriage in women with PCOS. Also, some of them have shown a reduction in the risk of miscarriage when certain interventions have been done. So they seem to indicate studies coming in late 90s and early 21st century have shown that there is probably an increased risk of miscarriage in women with PCOS, ranging from 25% to 62%. What about recurrent pregnancy loss? This association is not all that very clear. In fact, the incidence of PCOS in women with recurrent pregnancy loss is unknown, and we all probably would agree that the occurrence of PCOS in women with recurrent pregnancy loss is not that high. However, certain aspects of PCOS, like PCO morphology, is very often seen in women with recurrent pregnancy loss, and certain other aspects like hyperandrogenemia, insulin resistance, and obesity are also commonly encountered in women with PCOS. So, at the best, we can say there can be a tenuous association, but it is not proven. What could be the factors attributed to early pregnancy loss in women with PCOS? Of course, there is a long list. The first and foremost is multiple pregnancy, which we should avoid at any cost. And I would not address this issue, it's self-explanatory. So we'll look at the other causes, such as obesity, whether ovarian stimulation strategies itself will lead to an increased risk of early pregnancy loss, insulin resistance, and hyperinsulinemia, hyperandrogenemia, hyperhomocystinemia, whether these women are more likely to experience aneuploidic pregnancies, whether it's related to altered gene expression in oocytes, thrombophilia, and altered endometrial receptivity. So coming to obesity, we know that the association between obesity and PCOS is very intricate. And to put it in a nutshell, we can say that both these conditions coexist very often and tend to worsen the endocrine and metabolic dysregulation seen in each other. And as we can see in this graphic representation, the endocrine abnormalities or the metabolic abnormalities seen in women with obesity, whether they have PCOS or not, are very similar to those seen in women with PCOS. And one of the clinical manifestations, end result, would be an increased risk of miscarriage. There have been two important meta-analysis looking at correlation between obesity and early pregnancy loss. Of course, the population involved in these, included in these studies have been very heterogeneous. Some of them have included obese PCOS women, and some of them have been all obese infertile women, including non-PCOS and PCOS women. And this meta-analysis in 2007 showed an increased risk of clinical pregnancy loss in women with obesity, followed by the next one in the subsequent year, again showing an increased risk of clinical pregnancy loss in women with obesity, with or without PCOS. The next one has been, one of the factors has been, much studied factors has been impaired glucose tolerance. And it's very important and interesting to see that women who start their pregnancy, PCOS women who start their pregnancy with impaired glucose tolerance tend to have a significantly higher early pregnancy loss. And this association appears to remain even after adjusting for age, body mass index, duration of infertility, presence of hyperandrogenemia, and whether it's frozen or fresh embryo transfer. This increased risk of early pregnancy loss appears to remain in those who start their pregnancy with impaired glucose tolerance compared to those who have only impaired fasting glucose or normoglycemia. What about different treatments for PCOS, for anovulatory infertility and early pregnancy loss? This study, which looked at the role of ovulation with clomiphene citrate or metformin alone, or a combination of clomiphene citrate and metformin, did show that the pregnancy loss was similar in all these groups and was similar to what is seen in the background general population. So they did not particularly experience a increased risk of miscarriage in any of the groups treated for ovulation induction. And more recently, the Cochrane review has shown now that letrozole is considered as a first-line therapy for ovulation induction. The pregnancy loss, early pregnancy loss, is very similar in letrozole treated women compared to clomiphene citrate, there is neither an increase or a decrease with ovarian stimulation with letrozole. What about IVF and PCOS? We have heard, in the previous talks about the extent of abnormal endocrine environment present in women with PCOS, which would also translate to abnormal endocrine environment within the follicles. And also there is a huge list of altered gene expression and growth factor expression seen in oocytes of women with PCOS and also in the granulosa cells. However, whether it translates to any clinically important consequence is something which is important to see. And this study, which looked at the role of gonadotrophins and in gonadotrophin stimulation and what happens to blastocysts in women with PCOS and tubal infertility, did show that the cell number in these women in the blastocysts was very similar in both the groups, as was the pyruvate uptake in women with PCOS, where in vitro maturation was done from GV cells to M2 cells. There was no difference in the different groups of women, either with PCOS or without PCOS. So there doesn't appear to be, at least at the molecular level, a clinically important change happening there. And now looking at more clinical studies which have looked at the role of IVF and PCOS outcome. Of all the factors assessed, in this study, looking at the role of PCOS in occurrence of early pregnancy loss in women going through IVF, it doesn't seem to have any negative impact on the occurrence of miscarriages. In fact, smoking and poor quality embryos, which was again highlighted in one of the previous talks, seem to be the important factors in increasing the risk of miscarriage, and not PCOS per se in women undergoing IVF. This was later confirmed by a meta-analysis looking at the outcome of conventional IVF in women with PCOS, no increase in the clinical pregnancy rate. So the treatment modalities do not seem to have a negative impact on the occurrence of clinical pregnancy loss in women with PCOS. And this more recent study supports this data, and it highlights that probably there is an increase in the risk of biochemical pregnancies in women with PCOS undergoing IVF, and not necessarily the clinical miscarriage rate. Now, what about, much talked about LH hypersecretion in women with PCOS and early pregnancy loss? We now know that even though it was used previously as a diagnostic factor for diagnosis of PCOS, it's neither a causal factor for occurrence of PCOS, nor does suppression of high endogenous LH will lead to an improvement in the pregnancy outcome. And I just want to highlight this study, which has a very recent meta-analysis, which has looked at pre-treatment with combined oral contraceptive pill prior to antagonist protocol in women with PCOS undergoing IVF. This is a very common practice, and when high LH is seen, it's very common in India to put them on prolonged courses of OCP before taking them through IVF. And there does appear to be actually a negative correlation between pre-treatment with oral contraceptive pill and pregnancy outcome. So this is something to take note of. Oxidative stress in PCOS and early pregnancy loss. We know that PCOS is an oxidative state because there is decreased antioxidant concentrations within the cells of the both in the granulosa cells and the oocytes. And we know that there is reduced mitochondrial oxygen consumption with increased ROS production in the genital tract of women with both in the endometrial cells and the ovarian granulosa cells and oocytes. And also it is an inflammatory condition as such, PCOS. However, all these theories are very conducive to say that this could be one of the possible mechanisms in increasing the risk of miscarriage in women with PCOS, but there is no clinical data to support this hypothesis. And thank you, Madhuri, for lending this particular slide. So it's not only related to the gamete and embryo, but we also have to think of the impact of PCOS on endometrium, where there could be a huge amount of paracrine disturbances and impact of metabolic disturbances and thrombophilic events happening within the endometrium, altering its receptivity and causing early pregnancy loss. But again, there is no clinical data to strongly support this hypothesis. What about occurrence of familial thrombophilia in women with PCOS, and thus could be a causative factor for early pregnancy loss? There seems to be a slightly increased risk of presence of protein C and protein S deficiency in women with PCOS, and I'll show that data a little later. And also, PCOS is known to be associated with high plasminogen activator inhibitor activity, which can be a causative factor for increased early pregnancy loss. What about PCOS and aneuploidy? What I think this has again been addressed previously or mentioned by one of the speakers earlier, that PCOS pregnancies seem to be largely euploidic pregnancies, and in the miscarriages experienced by women with PCOS, euploid pregnancies were much higher than compared to those without PCOS across all age groups, whether they are younger or older than 35 years of age. Now, coming to association between recurrent pregnancy loss and women with PCOS, thrombophilia is one of the factors which has been evaluated. And as I was mentioning earlier, PCOS women seem to have an increased association with inherited thrombophilia, and protein C deficiency has been in particular documented at to have a higher incidence compared to women without PCOS. One another factor which has been found to be noted, particularly in Indian women with recurrent pregnancy loss, is the increased incidence of hyperhomocystinemia. And this is again associated with microthrombi in the placenta and recurrent pregnancy loss, and also often associated with insulin resistance. And there is some evidence that treating it prior to initiating pregnancy may help in reducing further miscarriages. So what can we do to reduce the incidence of early pregnancy loss in women with PCOS? One of the molecules which has been discussed extensively has been metformin. And initial data did suggest that in women who had had high early pregnancy losses, when put on metformin pre-conception and continued during pregnancy, there was a significant reduction in the early pregnancy loss. Yet again, one more study looking at similar parameters, those who had previous pregnancy loss and then put on metformin and continued during pregnancy, a significant reduction in the early pregnancy, in first trimester pregnancy loss. And also, this particular study looked at the correlation between increased plasminogen activating factor inhibitor and its association with insulin resistance. And both these factors, they found that there was a direct correlation between these two factors in women who had had a previous pregnancy loss. And once put on metformin, they found beneficial effect and also documented a reduction in both these factors, both the insulin resistance and PAI factor. So effect of metformin on early pregnancy loss, one more study looking at its impact on all women with PCOS going through any form of treatment who were put on metformin before conception and continued during pregnancy, whether they had had pregnancy loss or not previously, did find an improvement in the pregnancy outcome and a significant reduction in the pregnancy loss. So the evidence from these studies show that how metformin impacts an improvement in the pregnancy is multifactorial, and it has a positive impact in reducing hyperinsulinemia and insulin resistance, hyperandrogenemia, reducing the abnormally high levels of plasminogen activator inhibitor, and also, having a beneficial impact on women who are obese and with PCOS. And this was seen in an earlier meta-analysis. We did show that there is an improvement in the reduction in the clinical pregnancy loss, early clinical pregnancy loss in women with PCOS when treated with metformin. However, more subsequent data is, it has raised doubts as to whether metformin therapy is definitely beneficial, and more recent meta-analysis and systematic review have even though found benefits with metformin for various other aspects of ovarian stimulation. They have raised doubts as to benefits with metformin as far as early clinical pregnancy loss is concerned. And I think Anuja did make that point in her talk. What about lifestyle modification programs in women with PCOS? We know that lifestyle modification, again has a multifactorial benefit in women with PCOS. However, the evidence as far as benefits in reducing the clinical pregnancy loss is still not available, as seen in more than one meta-analysis, and that is very nicely captured in this recent review, which says that the data available suggests that obesity is associated with lower pregnancy and live birth rate in women with PCOS undergoing ART treatments. However, it remains unclear whether weight loss improves the outcome of this therapy. And as far as ASRM is concerned, it has very importantly concluded recently that any benefits we may anticipate with weight loss should be weighed against the time lost in achieving a pregnancy, as due to the impact of increasing maternal age over fertility. So, of course, in those subset of women who are with PCOS who are experiencing pregnancy loss due to thrombophilia or hyperhomocystinemia, specific therapy in the form of low-dose aspirin preconceptionally and low molecular weight heparin during pregnancy, and also for hyperhomocystinemia in the form of folic acid, vitamin B6 and B12 would certainly be beneficial. So in those women who are considering pregnancy, those women with PCOS considering pregnancy, particularly to reduce the risk of miscarriages, I think it's important to look at the lifestyle modification in those who are obese in a time-bound manner, and evaluate them for any presence of insulin resistance and address the issue if existing. And in women with PCOS and recurrent pregnancy loss, evaluation for thrombophilia would be important. So to conclude, PCOS may independently be associated with increased risk of early pregnancy loss, but the etiology could be multifactorial, and not all proposed etiological factors have been proven as yet. Treatment modalities for ovulation induction, whether clomiphene citrate, metformin or IVF, do not appear to adversely affect the pregnancy outcome. Obesity, insulin resistance, hyperhomocystinemia, and thrombophilic changes associated with PCOS may play etiological role. Metformin acts on multiple pathways and may improve successful pregnancy outcome. So even though many individual studies have said so, the recent evidence from meta-analysis have raised doubts about this beneficial effect. Lifestyle modification measures need to be balanced against the age-related decline in fertility. Thank you.
Thank you, Rekha, for a very excellent lecture. And we'll now go to the Q&A. So there's a question, and if a patient is sensitive to cabergoline, what is the alternative that can be used? It's for all. I mean, anybody can answer from all the faculty?
I think, I mean, if there is any concern about cabergoline, the other one is bromocriptine. I mean, we need to understand what the delegate means by sensitive. But if for some reason cabergoline cannot be used, bromocriptine is another alternative. And more importantly, whether hyperprolactinemia is definitely there. I think that is something that has to be confirmed, because very often women are put on these agents for very mild hyperprolactinemia, which could be secondary to PCOS itself or hypothyroidism. So we need to look at.
So for this is basically for patients who have
OHSS.
risk of OHSS.
Yeah.
So whether you could use bromocriptine also, other than, I mean,
there is any. I don't think there is any published data.
Yeah, because I also don't know about whether you could use any other drug other than cabergoline to reduce the risk of
Metformin has
OHSS.
a similar effect. I think metformin also acts on the VEGF receptors. So I think that is one other option one could use as an option. Of course, I don't know what dose you could use it in, but if
No,
you
but
look at
metformin basically,
how it works.
Pre-treatment, it has to be started.
yeah, pre-treatment, na, because most evidence say that if you, a small duration of metformin really does not help in reducing the risk of
So
OHSS.
metformin has a role in affecting the VEGF receptors, and that is why that's one way in which it helps in hyperstimulation. So I think that could be an option. I'm not saying it is the right option, but I can't think of anything else besides cabergoline.
Anything else from others?
Yeah, Madhuri, can you put us so that we can all see each other, please, rather than this open forum, see the speakers?
Okay, I'll just stop.
Yeah. So I will tell you, in my PCOS patients or any high responders, I start cabergoline on day one of, actually before stim start. So I start them on 0.5 milligram about 2-3 days before stim start, and while they're on medications, they're on cabergoline. And I've been doing that for more than 15 years.
Anybody else would like to say anything?
The mechanism of cabergoline is on the VEGF receptor, and there was a very small study quite a while ago with quite an expensive anti-VEGF drug that looked at that effect as well. But I think there were concerns about risk to fetus. Right. So they haven't proceeded with it. So cabergoline certainly is the treatment of choice. I think it depends. For symptomatic issues, post pickup, you can look at giving a little. It's certainly, if you think the albumin's low, you can try and reduce the ascites with some colloidosmotic pressure by giving albumin, just for comfort. But it's not really changing the mechanism.
Yeah, so I agree. I think if you are really suspicious post-retrieval or at the time of trigger and you haven't had the opportunity to modify things previously, especially metformin, and there's an allergic reaction to cabergoline, then you don't use it. I don't think I haven't seen data for bromocriptine for that 8-day period. So in general, we only give cabergoline for 8 days post-retrieval, if that's when you identify the high risk. And then I would use any of the other strategies that you just heard, the colloids, restricting the fluids and going up on the electrolytes, etc. But I haven't seen anything where you can switch for bromocriptine at that stage.
The next question is role of serial progesterone assays to make sure that the arrival of day 5 versus day 6.
For frozen embryo transfers?
Yeah, probably. I don't know, but they've not mentioned anything. They just said serial progesterone assay to make sure the arrival of day 5 versus day 6.
Yeah, I personally
probably
think
it could be in a fresh cycle wherein you could do a progesterone level, and whether you could transfer it on day 6 or it's in a FET. I'm not very sure.
I'm not aware of any data regarding this. There's data like 3 days later looking at progesterone, but progesterone secretion, I mean, you're supplementing with progesterone,
Mm-hmm.
it doesn't make any sense. So I don't think it has any role once you start progesterone supplementation.
Correct.
There
There's
are,
no cutoff. I wouldn't
Yeah.
recommend it because you don't know what levels to use. Yeah.
yeah, I just heard somebody speak last week, and they said that they use progesterone levels before they do the embryo transfer. And depending on the levels, they decide whether they should do a fresh or a frozen. Wherein I think they said the cutoff was.
Yeah, there's one paper from NYU looking at this. It's a retrospective review that showed if the progesterone level is a bit lower, then the pregnancy rate is a bit lower. But you know, there's nothing prospective. What are you going to do? You're going to push your progesterone and tell the patient, okay, we're not going to do your transfer. It doesn't make much sense.
So there's another question. I mean, Dr. Devika says that this may be out of context, but would you freeze embryos in a poor responder to prevent asynchrony between the endometrium and embryo?
I mean, back to the progesterone issue. So this is Venetis's paper on 60,000 cycles many years ago. So poor responders, you know, that 1.5 value that, you know, the Bosch paper in 2010 came up with. So Venetis showed that in poor responders, it's closer to about 1.2. And in high responders, it's 1.8 is perfectly fine. It's impossible to predict something like this. If you're planning to do a fresh transfer and basically you have an expanded embryo on day 5, I will say transfer it. If you're worried, you can freeze that embryo, do an ERA, find out if it's receptive, and then do a frozen embryo transfer. But the cost becomes a huge factor. And as I showed you, that paper from Duke showing in poor responders, doing a fresh transfer has a higher chance than an FET. So if you're worried, I mean, if the progesterone is above 1.2, 1.5 in a poor responder, I think there's a logic to try to freeze. If you have 3 eggs and you get 1 embryo and your progesterone is 1.5, I think there's logic to try to freeze that embryo and then transfer. But you always worry, if you don't have a good lab, are you really short-handing this patient or not? Short-changing that patient or not? So you have to look at the balance of everything.
The other question is how to deal with a poor responder PCOS woman.
Those two don't mix.
I think it is resistant PCOS.
Right.
Yeah, that's not a poor responder.
Yeah,
That's
it's
you just did not stimulate them right.
I think Anuja has answered that when she spoke the last bit of her talk. The next question is ideal dose of gonadotrophins for an AMH of 8 with normal BMI with previous 5 cycles of ovulation induction cycles showing no dominant follicle.
Okay. Ovulation induction using what? I would suspect not gonadotropins.
No, probably oral ovulations. Nothing
Right.
repeated.
So that's a non-responder with orals. So you would expect they would respond with gonadotropins. But
Yes,
the
so
ideal
they are asking
scenario is
the ideal dose of gonadotropins for such a patient.
what dose?
Ideal dose of gonadotropins for such a patient.
Right. So
You start
we
low,
should discuss this. I'm gonna
start low and step up until you get a response, and then go back to previous cycles if you get no response and figure out your doses.
Yeah, and I think if they want some guidance where to start, we typically start between 100 and 150, depending on the BMI, antral follicle count, and AMH. So I know you gave us just an AMH. I would put all that in perspective in the age. So take the whole picture. And then I agree, you have to give a little time. You know, you don't bring them back like every other day and keep stepping up. Give a little time to prime, and then hopefully there will be a response. It is a little tedious and annoying from the patient's perspective, but I think that is the best way to do. Like we spoke a little earlier, you don't want this huge response and then getting a large number of eggs.
Yeah, otherwise they're gonna explode. So start them on 100, 150, whatever you want to start them with. Bring them back 5 days later. I would not recommend bringing them back any sooner. You're not going to see anything any sooner.
And we typically in obese patients see that we need a slightly higher dose.
No question.
You might have to modify that with the Indian phenotype and profile. You know, I wouldn't start much higher if your patient just has the visceral adiposity and is otherwise a normal BMI.
Yeah, she had a normal BMI, but I
Yeah.
aimed to fit here.
And then type of gonadotropin is important. I mean, you mentioned a bit, Madhuri, but I think when you use a REC FSH only, you're going to drive them much faster and much more aggressively. So in my PCOS patients, at least, I only use HMG with them.
The next question is a known case of PCOS with 2 abortions around 7 weeks. Karyotyping of the female shows chromosomal elongation of the P arm on chromosome 23. How to proceed?
That Madhuri, that have they mentioned whether it is a normal variant or
No, no. Did not mention it.
most of these are considered as variation of normal. I think, you know, in this particular instance, they need to look for other causes of pregnancy loss. And what would have been beneficial would have been, in this particular case, karyotyping of the abortus.
Mhm.
But we need to look for other causes of recurrent pregnancy loss in this. And I would, you know, like I would take the help of a geneticist, reproductive geneticist in this to see whether many of these elongation of the P arm is usually, it's considered as a variation of normal. So I would first like to confirm whether it is so.
Yeah, because they've not mentioned which chromosome also. Yeah. The next question is role of metformin in PCOS patients who are for IUI. Is there any role?
It
Yeah,
would be
there's
the
a
same. Sorry.
There's
It
a
works
role
in everything.
metformin before you do any treatment,
Yeah.
before
It
you even
works.
talk about IUI. That's the first thing. Many of our patients get pregnant by just going on metformin. You don't really need anything.
Somebody's asking about the dose and duration of cabergoline and also the route. As we know that cabergoline is long acting, should we use it daily?
No.
I think Dr. Anuja said that we use it daily for
OHSS.
For
Yes,
OHSS.
Yeah, for OHSS,
Otherwise
it's a
it-
daily dose for 8 days, correct. Mhm.
Otherwise, it's twice a week.
yes.
If you're doing hyperprolactinemia, that's right. Mhm.
Twice a week.
No water for OHSS. Does it predispose to thrombosis?
No, it doesn't. So I actually, you know, remember what's the issue, how OHSS happened with VEGF. I mean, you get basically extravasation from the vessels out into third spacing. So this is why even giving them colloids really don't work as well. What works extremely well in these patients are actually salt. So you need to prevent them from drinking regular water and just have them drink, you know, in the US, we have something called V8, which is a mixture of, you know, vegetables with high salt content. I tell them to go drink soups, drink nothing with water. So no coffee, no tea, nothing whatsoever. So, and no fruits that have a lot of water in them. So definitely no watermelon or things like this. So I really restrict their fluid, their water, not their fluid. They can drink as much tomato juice or V8 as they want. I've been doing this for 20 years. I've never, ever had anybody throw a clot before. But I'd love to hear what others have to say.
What happens though is that they get hemoconcentrated and their hematocrit becomes very high. And you can, we've had arterial thromboses that have been quite significant. So we would generally do those fluid restrictions and look at salt intake and things like that, but also give Clexane.
Yeah, I mean, you measure their CBC, you measure their LFTs, whatever. I mean, if their crit is 55 or above, you need to give them prophylactic Lovenox for sure. But if they're below that, you know, you're perfectly fine. The key with OHSS is really catch them very, very early. Okay. So hence why you would not want to do a fresh transfer on these people and get them pregnant. And there's the early OHSS and the late OHSS. Duru gave a great talk on OHSS. So seriously, and if you're worried, you need to watch them very, very closely. Don't just send them home. It's like, okay, come back. We'll see you in 5 days. If you're really worried and they tell them to call you if they have shortness of breath or if they gain more than 2 pounds a day, we give them a sheet called OHSS instructions. Luckily we don't do that anymore. I'm worried that many docs around the world are not going to have any experience with OHSS moving forward because of GnRH agonists. So when they see a case of OHSS, they're not going to know what to do with it. And I used to tell my patients, at least, that I'm worried about OHSS. Please do not go to the emergency room, because the first thing they do, they put an IV and they give them 2 liters of fluid. And that's, you just made a patient who is critical much, much more sick by doing this. So the key, tap them early and often.
I think to clarify that question, when they're asking you, if you don't do the water, do you have thrombosis? So we're not saying don't do fluids. We are saying don't do just free
Correct.
water.
No water.
It's okay to do the water with electrolytes. And yes, there is a risk of thrombosis. And over a hematocrit of 45, we start the blood thinner because there is a known risk. But those are 2 different things. We are not saying get dehydrated and don't drink. We're just saying drink something with a high electrolyte content. So in India, you get the electrol and put that and mix it, or any of the other options that Dr. Fati talked about are totally fine.
A very high AMH, would you wait for a few months for pre-treatment with OCP before stimulation?
I mean, I do. I put them on metformin for at least a couple of months. And as I showed in that presentation, if they're really following the low carb diet and they're really watching their carb intake and they take the metformin, the inositol, that AMH will definitely drop. If it doesn't drop, they're not compliant. Anuja, agree?
Yeah, Louis, I mean, Duru,
So I think it's a little different with the AMH levels, like in your obese patient versus the lean, right? So your lean patient with the very high AMH, that's really coming down with age as she gets older and the ovaries shrink. It's not really reducing as dramatically. With obese patients, we do know that the AMHs are lower, and there is a mechanism whereby there is suppression of AMH. And so with weight loss in that group, however, when you look at the bariatric surgery literature, it really hasn't panned out that much. It's not that, you suddenly see their AMH double with a 100-pound weight loss. So it's a different mechanism for sure with weight loss in the obese patients. You do better and they will start ovulating and they'll have menstrual regularity. But I think the patient with the high AMH and the lean profile that you see in India, I'm not entirely sure the weight management in that group is going to drop her AMH level.
the next question is stimulation based on AMH values.
The higher, the lower. So the higher the AMH, the lower the gonadotropin the gonadotropin dosage you should use.
Yeah, and I think the maximum dose, what we need to give even with low AMH basically is about 300 to a max of 450, nothing more than that.
Actually, AMH corresponds so well with the antral follicle counts that the more the number of follicles you see on a baseline ultrasound, you'll find that the AMH levels are higher. And that itself shows you that when the AMH is high, you need to start with a lower gonadotropin dose.
I mean, the AMH should not alone be the driver for you. I mean, at least in the US, we are much more AFC driven than AMH driven. And we all have had patients with an AFC of 6 with an AMH of 2. That doesn't correlate. So for at least most of us, we go by AFC to decide on the amount of gonadotropins, type of gonadotropins, everything. But again, when you're talking about PCOS, they usually have a high AMH and they have a lot of AFC, and that we have to be very gentle with the stimulation.
The only proviso there is BMI, because if you can't get over a threshold, you'll not get any stim at the beginning. So I tend to actually use the step down protocol with them, where I'll start a little bit higher because of the BMI, get the follicles growing, and then start winding back through the cycle to stop the smaller ones growing, so that you can just get a good number. But sometimes if you start too low, you'll only get 1 or 2, and then you'll have, then we would cancel that cycle. So
yeah, you need to add at least 75 more if their BMI is higher. Sometimes you may have to double the dose if they're really overweight or obese.
The next question is whether metformin has to be started in a smaller dose like 500 and then gradually increased. And what's the best protocol and the maximum dose of metformin that can be used?
I can
I
take
think
that. If you're doing metformin more for the metabolic profile or ovulation induction, I tend to start it at a lower dose only because the GI side effects are quite terrible. Over a third to 25% of patients will have significant persistent nausea. They may have diarrhea. So we do the 500 extended release the first week, or at least 5 to 7 days, then bump it up to 1,000, bump it up to 1,500. In the REI literature, you'll see 1,500. In the medical endocrinologist sort of use 2,000. So I don't think there's a real consensus between those two doses. If you do extended release, you can do it all at the same time for the patient, which is convenient because at least in the US, these are huge pills to swallow and it's annoying for them. So with a full stomach through the day, if they just take it at night and then they're done, that works out. But which means it's going to take about 3 weeks to ramp up. So it's going to take a while. You can't really start with IVF stimulation. You'll be done with your stimulation and retrieval by the time you get to the max dose. So really all of this needs to be done a little earlier.
I mean, I personally start the diet first. I've been using metformin since '96, but at the time I used to change their diet and put them on metformin at the same time. I stopped doing that many years ago. I put them on the diet for at least 2 to 3 weeks before I start metformin. And I personally don't use the extended release except for somebody who does not tolerate after the diet the usual metformin. So I would rather have them use the regular metformin when they're on the diet, because when they cheat on the diet, they get side effects. So they know they're cheating on their diet.
or they stop.
No,
Right.
they don't.
Yes. The non-compliance is a bigger risk.
Usually the great thing about our patients is they're really compliant. That's a huge plus.
I tend to use the extended release. I don't think ours are quite as compliant.
The next question is, a PCOS woman with high LH levels on day 2 of the cycle, should we start COS with FSH alone and not add LH or HMG? And is there a cutoff of day 2 LH where we should not use HMG for control ovarian stimulation in a PCOS woman?
I don't measure LHs, so I can't answer that question. And nearly, if I'm doing ovulation induction, it's a different story. But if I'm doing IVF, all these patients, I put them on the pill beforehand. But again, back to what we've been discussing since the beginning of this, all our PCOS patients, we try to change their diet, put them on metformin, put them on inositol. I try to do this at least 6 weeks before I do an IVF cycle. The longer, the better, actually. And there's ample data in the literature that this is the case.
And I think, Madhuri, whether we use HMG or REC-FSH, it doesn't make any difference. The exogenous LH will add very little to the value of what we measure in the serum. So I think what Dr. Sharara said, we decide based on what we would like to do pre-stimulation and whichever molecule we would like to use during stimulation. It should not be determined by the LH value.
Yeah, I'm not so sure measuring LHs on these patients is of any value whatsoever.
Anybody else would like to comment on this?
No, I'm in agreement. There's really no value in measuring it at baseline. It's a pulsatile hormone. You're going to get a high level on and off in even people who don't have PCOS, so it's not adding or changing anything. in terms of our treatment. And then clearly for IVF, we do the short course of birth control as well. I think I put that last slide. It's going to be nice and low. And when you add an antagonist, it's nice and low. So in general, there is no value in measuring it at baseline.
Therefore, NIH also has removed the criteria of FSH-LS ratio from the diagnostic.
For the same reason, it's the pulsatility. You don't get an accurate result. Yeah.
Yeah. That LH-FSH ratio has not been a criteria in how long now? I don't think people should.
For a long time, since 2012.
Please do not look at this ratio anymore. It is worthless.
Yeah, since 2012, it's been removed from there. Yeah. So I would just like to say that now we have our next 2 workshops. The next one is on nutrition, and the last one is on obstetrics and PCOS. And then we have our annual conference, which is on the 21st and 22nd of November, where it's a multidisciplinary, where we're going to discuss everything right from endocrinology to dermatology to GI and reproductive medicine. And I would invite Dr. Durusha to conclude the workshop today.
Thank you so much, Madhuri. I think it's been a great workshop. We've had excellent speakers and excellent discussion. We will be hosting the complete workshop on our website, which will be open to the PCOS Society members. And we will send you the link, all our speakers, and we would like you to share it with whomever you would like to share it. Thank you very much for being with us. And I would like to personally thank Madhuri for organizing everything and putting everything in place, all the logistics, etc. And also the speakers for their brilliant discussions and lectures, and all our delegates who have been attending. I think by morning we had more than 1,500 registrations. I don't know what the count is now, but I think we've gone beyond our capacity because it's live on YouTube also. Because when you go beyond your capacity, it almost goes into the live YouTube mode. So we'll send you all the details of our program, and thank you so much for being with us. And thank you, Madhuri.
Thank you very much.
Thank you.
Yeah, I thank all of you all, especially Louis, because it's very late in Australia, and Anuja and Paddy for getting up early on a Saturday morning to join us, and Dr. Rekha and Sujata for really adding value to our workshop today. And we would definitely send you the link for our next workshops. So it would be great if you could join in. Thank you all very much.
Thank you.
Bye-bye.
Thank you so much.
Bye-bye.